Professor Mohamed Hamza. He will talk about new era for wound management.
Thank you, Dr. Musad, and dear panelists. The new era in diabetic wound management. The diabetic foot patient is a multisystemic patient, so don't deal with him as a whole, but treat him as a whole. The dry skin makes the skin look and feel roughly, itchy, and flaky, scaly. So the location where the dry patient form vary from person to person. It is a common condition that affect the people of all ages. However, seniors of the people with a medical condition such as diabetes mellitus have increased chance of the dry skin. About 1 in 3 people suffer from dry feet. When the age is advanced, this number is about 60%. So, as we grow elderly, the skin creates less collagen and elastin. So your dry feet are also more than vulnerable than feet with hydrated skin. So you can increase the risk of open chafing, and you enjoy the less protection against the bacteria. So how can we deal with the dry feet at home? By also washing our feet daily with dry the feet, especially between the toes. Also, you can feel between the nail and the toes. Also, you intensively hydrate your feet after every shower and bath every night before going to bed. Apply the hydrating cream on the entire foot and carefully massage it in. Also, it is preferably use a cream with low urea content. Also, you should wear a cotton socks which allow the skin over the feet to breathe. Also, put these dry, clean socks every day. This is a randomized control study on the effect of the Zimulge on treating of the diabetic foot ulcer. The diabetic foot ulcer makes about 50% of all non-traumatic amputation, with peripheral neuropathy and vascular disease are thought to be a major factor causing chronic foot ulceration. The diabetic foot ulceration is a major complication of diabetes mellitus, with approximately 5% of diabetic patients which have the foot ulcer. The current standard treatment for diabetic foot ulcer consists of restoration of adequate vascular supply, debridement and the treatment of the infection with relief of the pressure. The patient and the method. This study was a prospective randomized placebo-controlled single study conducted between September 2023 and July 2024. The study was designed and conducted in accordance with the Declaration of Helsinki guidelines after taking the patient consent prior to the study. The included patient in this study was type 1 to 2 diabetes mellitus with aged over 20 years. Though the ulcer was more than 1 centimeter for more than 4 weeks, it was 1 to 2 of Wagner stages. Those with adequate circulation in the foot confirmed by palpable pulses. Also, those with signed consent from all of the described patient. The patient with osteomyelitis, systemic inflammatory disease with autoimmune disease, and the DVT was excluded. Also, the pregnant and those patients who was under immunosuppression drugs, and also these patients which has systemic wasting disease like chronic obstructive pulmonary disease was excluded from the study. The basic dressing protocol was standard as was through cleaning the wound bed and margin with normal saline. Additional debridement with removal of the necrotic tissue and expose the healthy bleeding margin after washing with saline. Trimming of the corresponding dressing material according to the size of and shape of the ulcer. With direct application of the dressing material to the wound bed and then covering the wound. The dressing change was performed during the scheduled weekly follow-up And however, depending on the amount of exudate, additional dressing changes was performed for 2 to 3 weeks for 2 to 3 times per week. The primary endpoint was complete healing rate at 12 weeks after commencement of the dressing. Complete healing was defined as complete revitalization without discharge. If the diabetic foot was complete healed before this point, the duration was recorded and the patient received a final laboratory test in advance. The secondary endpoint to compare between the rate of the diabetic foot ulcer between the two groups, the mean duration to reaching about 50% of the ulcer size reduction and velocity of the healing were evaluated. The healing velocity also was calculated as a percent reduction in the ulcer area per week. So further median time taken to achieve 50% of ulcer healing was estimated using Kaplan-Meier survival analysis. By studying both two groups and the comparison between both of them, we notice that the Zimalge gel showed significant superiority over standard treatment. The patient on Zimalge gel achieved complete healing rate at 12 weeks, which was almost double the number of the patient on standard treatment, while Zimalge gel used in the second group also show significant superiority over standard treatment. The patient on Zimalge needs about less time to achieve about 50% of ulcer healing rate. These are some of our cases with the stump of the PAVSS 2 ulcer. It takes about 2 weeks at the first stage and about 1 week, so the final time to healing of this ulcer was about 3 weeks. This patient was chronic venous insufficiency, and diabetic patient also takes about 2 weeks to reach this picture. So the Zimalge is quite safe and sufficient dressing for treatment of diabetic foot ulcer, while the dressing with it helps in acceleration of the wound healing. By focusing on complete healing, we can telling that our dressing is ideal. So more researches are advisable to accomplish and point this result. Thank you.